Hey, good afternoon. Welcome to this sixth in our series of 7 blog and live Q&A sessions. My name is Matt Bobman, and I'm excited you made it. Today, our guest blogger is McKenzie White. McKenzie is a current PhD student in movement science at the University of Michigan. She's doing some really cool research and developing novel technology and techniques to understand muscles and other aspects of movement better. McKenzie, thank you for joining us.
Thanks for having me.
Well, I thank you for writing a blog, and I really appreciate your post and how much you were willing to share. I do want to hear more about your experience, but before we get started, could you tell me a little bit more about you, your lab, and what you're interested in researching?
Yeah, sure. So as you kind of mentioned, I'm a third-year PhD student, my second year at University of Michigan. I'm involved in ACL research now, but a lot of my patient experience has really guided my interest here. So hopefully in the future, I'll be able to kind of adapt into more alignment specific methods in research. But yeah, I work under Lindsay Lepley. She's a prominent person in ACL research, and we have a small lab. I'm her only PhD student at the moment, so there's a lot that we're both doing, but it's fun. I love it. So.
You get a lot of attention.
I do.
That's
for
awesome.
sure.
Has the pandemic slowed some work in the lab? Have you been able to collect research or collect data?
We actually haven't been too much affected. We moved universities 2 years ago, so a lot of our time has been really setting up our human lab and rodent labs. So kind of the pandemic was kind of beneficial to that, so we could kind of do a lot of data processing and implementing new technologies, because that's all done offline, really. Like, you don't have to be in the lab for that. Yeah. So yeah, we didn't really get impacted, thank goodness. So we were lucky.
Yeah. And you said we moved, so you and Lindsay moved together, right? She took you with her.
She did. She took me with her. Yeah, she took me with me. She took our lab tech also. That was here last year. Came with us from UConn. So yeah.
That's awesome. I love it. Okay. All right. So I'd like to just start by hearing your story. So can you tell me more about your surgical history? Tell me when you learned about your malalignment and how that whole thing kind of unfolded, whatever you're interested in sharing.
Yeah. It's a long medical history, but I'll try to give you a brief overview. I was born with clubbed feet and a 17-degree valgus deformity bilaterally. I didn't learn about the valgus until, I was like 18 years old, I would say. So the first 18 years is really focused on my feet. I broke my left foot 7 times, my right foot once in 3 places. I have 2 screws in my right foot. I've been in and out of wheelchairs, the whole 9 yards. And then that kind of transition after my feet went to my knees. I was around 18 when my knees started. And it was just enough time to get to college soccer. In between all my feet issues, I was somehow managed to keep playing. And my knee pain started my freshman year of college soccer. I went to the doctors and, started this whole ordeal with trying to figure out what actually was going on. And I found a surgeon who really focused on autologous chondrocyte implants, so the cartilage transplants. And he also happened to do realignment procedures. And that's when he found, and I was told that I had 11-degree valgus on my right knee and 6 on my left. And that was the reason for my knee pain. Yeah.
Is that 11 and 6 above normal, or 11 and 6 from 0?
11 to 6 from 0. So normal is definitely 0 to 2 degrees. So it was 11 to 6 from 0. Yeah. So at that point, he wanted to do the ACI, but he said he wouldn't do the ACI without realigning my legs because the cartilage would just wear down again. So,
you're 18 years old. How bad was the cartilage?
It was the pain was bad. I couldn't go upstairs. I played for about a month into my college soccer season, my freshman year. And from September to November, I barely made it through the season. So after that, I was like unable to do most activities. And it was pretty bad. I think the Carlos defect was like almost 2. I think it was 0.8 by 1.2 by 2 centimeters of a Carlos defect that was impacting right under my patella. So that was really the cause of it, but they didn't really know exactly what to do at the time. Some people wanted to do like microfracture surgery. Others said it was like caused by hamstrung knee, which is really just tight hamstrings. And I was just going to a ton of doctors trying to figure out what to do. The hamstring knee was an interesting one. Doctor for the Dallas Mavericks told me that one. So,
and you had your first realignment surgery at, how old were you?
It was 2013 and 2014. So I had my right leg reconstructed in 2013. And that was the distal femoral osteotomy and the tibial tubercle osteotomy. And then my left leg was done 2014, a year later, because my surgeon wouldn't do it any sooner than that. Due to the rehab and how much healing had to be done.
Yeah. And is that figure 1 in the blog, the postoperative radiographs?
Yes. Yep. That's after both of them.
Let me see if I can pull that up, because that's a significant. Let's see here. What do I want to share? Chrome tab.
Yeah, a lot of hardware.
There we go. A lot of hardware, yeah. Okay. Yeah. So that is, that's okay. That's significant.
Yeah, you can see like the distal femoral osteotomy where they remove that wedge. That was actually done for like the realignment purposes, and the tibial tubercle osteotomy isn't really done for realignment. It's done to unload your patella, and they basically shave off your tibial tubercle, move it anteriorly and medially. And it's supposed to unload your patella and correct some of the maltracking that was occurring. But it's not a highly recommended procedure, according to the godfather of rotational deformities. He said it was a terrible procedure. So.
Oh, no. Well, you don't want to hear that.
No.
Sorry. Okay.
That's fine.
All right. So we're tracking along here. And were you feeling successful, or were you feeling like, hey, we're on the right track here? Where, you're like 21, 22 years old. You just had 2 major lower extremity reconstructions, and you're feeling positive, I hope.
Yeah, I was. At the time, after my right leg was reconstructed, that was my first leg in 2013, and I was able to walk 3 months later after I did the bed rest and all the fun rehab in the acute phases. It honestly was like amazing. My leg was straight, number one, and that was like what I considered at the time like a biggest barrier of what was limiting me and impacting me from getting back to playing soccer again. And it also was like a lot. This is probably a weird way to say this, but it was a lot easier to walk. It just felt more like fluid. I don't know how to explain it in a better way than that, but. It was like I was happy. Like I would look at my leg and I'd be like, wow, like, it was worth it. Whatever I had to go through was worth it. So getting my left leg done wasn't, a huge concern or anything. It was exciting because I was going to be able to allow me to play again and, continue fighting to play. So.
Yeah. Okay. All right. Well, what happened from there? So you made it to your 3rd year of college soccer. Yeah,
I made it to my 3rd year of college soccer. So
that's very impressive, by the way.
I wasn't playing, so I was just on the team.
Okay, but it's still impressive. Still a lot of work, dedication.
Yeah. It was honestly my coach that kept me on the team throughout this was incredible. Like I don't know many, Division I schools that would keep their players on a team after being injured for 3.5 years. So I found my doctor who actually told me I had the malalignment and wanted to do the surgery in 2011. He did a knee scope I found him in 2012. I had my surgery in 2013 on my right leg, my left leg 2014. I rehabbed all of 2014 and into 2015. So I got cleared in May 2015 at this point, and I had about May, June, and July to get back to being attempting to be a Division I athlete after being injured for 3.5 years. So I basically just went pedal to the metal and tried to do that. And at the time, everything was okay. I mean, it was not, I was not pain-free, but I could do it and I could play. And that was kind of everything to me at the time. And then slowly when the season started and everything got going and I got into really going for it, the pain just grew exponentially. And I barely made it through the season, but my coach put me in a game, which meant everything to me at the time. It was a pity one, but it was like, a big climbing a mountain for 23 years at the time. So to be put in that game was kind of like I had made it, and it was like, it just meant a lot. So after the soccer ended, though, it's kind of like I could focus on figuring out what was going on and what went wrong, and started going back to doctors and working with my PTs more and strength coaches and all that, just more than I was during the season. And it kind of became pretty clear that something was going on that wasn't right. And sorry, go ahead.
Well, it was mostly knee pain at this point again?
It was mostly knee pain. Yeah.
Okay.
My hip pain started, I guess about a year. Actually, probably pretty close to when. Probably like 5 or 6 months after soccer ended. So like, I don't know. So not long after soccer ended was the hip pain.
Okay.
Yeah.
All right.
Yeah. I went back to my doctor at that point, tried to figure out what was going on. That's when he said he didn't really know what was happening. He couldn't really help me. He said that 2% of patients have an adverse reaction to hardware, which was, something new I hadn't heard. And I knew that wasn't the cause for all the symptoms I was having, but we removed the hardware anyway because, that was the only thing we could do at the time. And I just continued going to doctors since then. So. Okay.
And when was the conference with the German surgeon?
So that was in 2019. So basically during all that time, I started my master's at the University of Buffalo, where I went to school, and I was doing trying to figure out what was going on, doing gait analysis on myself, and still going to doctors, but we weren't really figuring out the level of detail. We had suspicions that there was internal rotation of my right hip and structural ones, not just range of motion ones and mobility. But nobody was really able to give a clear answer. So when I went to that conference, I had an understanding that something was going on, and we had suspicions that it was another structural abnormality. And at that conference is when I saw, actually my surgeon was there at the conference, and he said my legs looked great, that everything was great, everything was perfect, they were straight.
He didn't say that publicly. They didn't stand up at the mic and
no, not publicly. Before the presentation. Before the presentation.
Okay. I picture him rebutting to your question.
No.
Okay.
No, he did not do that in the middle of the presentation, but he was there. And at the presentation that's when I got up, and the surgeon was giving kind of explaining what he had done wrong and what they had learned since 2015, which I can speak to a little bit later on. I think one of the questions was related to that. So I can speak to that a little bit more. And I ended up speaking to that surgeon for a while afterward, and he was super helpful. He looked at my x-rays, we had a good conversation, and he was who referred me to the doctor that's actually really close to me, an hour from where I live. He did a 3D rotational CT scan, and that's when we realized the extent of the abnormalities now, which was roughly 25 degrees of asymmetries between limbs. Yeah.
Okay. All right. Well, I don't know if you mind sharing. I'd be just curious to know, like, what's your functional level now? I mean, you mentioned a handicap placard and you mentioned PT visits in your blog. Is that where you're at currently? I mean, can you run? Can you?
No, I definitely can't run. Running is not in the equation.
Okay.
I'm still in PT, so I've been in like constant PT since I was like 10 years old when my feet started breaking. That's just kind of what I have to do for maintenance purposes of everything.
Yeah.
But I mean, I can move. I can't like walk far distances. I can't stand for long periods of time. But if you look at me, you wouldn't like know that I have a handicap sticker. Like people have actually like said like you're not handicapped when I park in a handicap spot. So
Yeah, that's not cool.
yeah, it's definitely I can still do things, but it's not right. I have a lot of pain. I have hip pain. I have a labral tear in my right hip. I likely have one in my left hip. But we make the best of it. You just do what you can. So
Yeah. And any plans to try to correct the rotational deformity? I know you mentioned a bow-legged outcome, which would kind of put you back where you started, wouldn't it?
yeah, which is why I don't have. I kind of stopped searching for. That surgeon was not the godfather of rotational deformities, but a fellow that worked under him is who kind of gave me that recommendation that he could do a proximal hip osteotomy to correct some of the internal rotation on my right side. And when asked, how that would affect my distal femur, he said I would become slightly bow-legged. I also asked, how does he know it's not originating from my hip? And he said, you should probably go to a hip specialist. So basically, I stopped looking for answers in the surgical answers, I guess, because I think we're so far off from having the right preoperative assessments that I can't really feel confident in that it's my best option. So we're trying to just manage it and see how long I can go for, I guess.
Yeah. Wow. Okay.
Yeah.
Well, that's incredible, and I think the picture of you like in your master's degree saying like I'm going to use my own gait as a teaching tool or learning tool to help try to understand this better is just like, it's kind of heartbreaking. Like, I'm sorry that there was just so much uncertainty, and there's still a lot of uncertainty, and that you've had to endure this. I mean, yeah, I'm sorry. It's terrible.
Well, thank you. But honestly, it's there's a lot of pain and a lot of lessons that I've learned through it, but it has made and molded every piece and part of who I am and how I operate and everything. And I've learned a lot about myself, and I don't know, I just found power in it, I guess, and let it empowered me. So don't be sorry. Yeah. It's why I'm in research. So it's
and you're doing cool stuff. And we'll talk about that here. So I just have a couple more questions about your personal story here. And the first one, which I guess you just answered, was you don't seem bitter. Why aren't you bitter? I guess you've been really using this and fueling your career and trying to help other people through your research.
Yeah, I think I really just choose not to be. I don't think it would serve me well to be bitter about it. I think it. Yeah, let it empower me, and I want to change these surgeries for other people so I don't have to go through it. So choosing to be bitter isn't going to help me do that. So yeah, I guess it's just a choice, I guess.
Do you think the surgeon's sort of dismissal of you, saying that your alignment was perfect, do you think that was more of a lack of, it was like an ego problem, or do you think it was more of a problem of just not understanding the entirety of the picture?
Yeah, this one's a little bit tough to say. I don't know from his perspective.
Right.
I can tell you, I personally believe it's largely about ego, but he also, like, maybe he's fearful of malpractice, or I don't know. I do find it hard to believe that you can be unaware of how it would be impacting all of these other things that they're not considering or acknowledging. But yeah, I guess I don't have a direct answer because I don't know from his perspective, but I would find it hard to believe that he's unaware, I guess.
Okay. Yeah. Well, that brings me to the next question, which is, what's the current best practice for evaluating lower limb alignment? And is the current best practice good enough?
Yeah, so I might share my screen for this one because I can kind of explain a little bit more detail. Let me see. I can do it. Come on, Kenzie. Can you see this?
Looks good.
Okay, sweet. So yeah, I can kind of give a little bit more background on what kind of my surgeon did wrong, and kind of what we've learned. So in 2012, like, obviously there's the mechanical axis, which mechanical axis of your lower limb, and it really gives you a measure of valgus or varus and where really overloading is occurring, but it doesn't really tell you where a malalignment is originating from. And as of 2011, they're performing all realignment procedures at the tibia. So 99% of them were performed on the tibia. Apparently that was because it was easier to perform at the tibia, which I don't know what that means. So I can't provide, information on that. That's what one of the surgeons had told me. But it doesn't tell you where the malalignment is actually occurring. So in 2015, there was a study done that showed that basically they started taking into account joint angles and orientations. And when they started to do that, they realized that 10% of the malalignment were actually occurring at the femur rather than the tibia. And another 10% were the malalignments were originating at the tibia and the femur. So they would require a double osteotomy. So that's where the 20% comes from, when the surgeon admitted that he performed the surgery on the wrong bone of 20% of his patients. I think I have another slide here. So in 2019 was when the surgeon was actually speaking to us at the conference. He kind of explained that when you look at the tibia and the femur independently, and you take into account the joint line congruency angle, which should be an incline of 2 degrees, because basically it's not that important when you're just at stance and you're only 50% weight bearing on a limb, but when you're 4 or 5 times body weight on a limb during jogging, running, any really dynamic movement, jumping, that joint line congruency angle goes from oblique 2 degrees to horizontal. So it's able to give you a more even distribution amongst your cartilage on the medial and lateral sides. So when they started taking that into account, they realized that they could figure out where these malalignment actually were occurring at, whether it was the femur or the tibia, and they started to get better outcomes. But at the conference, as I mentioned, I asked them if they were taking into account rotation and how were they ruling out rotation, and they really weren't doing anything as of 2 years ago. And that's just kind of like one piece of it. So torsion is one thing, looking at rotational abnormalities. There's also femoral torsion. So femoral torsion can be at your femoral shaft or your femoral neck, and that can be, actually the femoral shaft abnormalities and malalignments have been linked to ACL injury. So that's, something to think about, but that's all I will say about it related to ACL injury. We also have to remember that these x-rays are taken in a static position, and there's no indication of how we're moving dynamically. And there's also muscle considerations. This one's a little bit more far-fetched for, if I said this to a surgeon that are doing these surgeries, they'd look at me like I'm crazy. But if you look at like CP populations and people with cerebral palsy, they look at primary, secondary, tertiary symptoms in order to consider things like muscle considerations, because when you're altering joint position, you're altering line of actions. and the intrinsic properties of muscle, looking at force length, force velocity relationships. So I think we have a long way to go, in other words, but we're definitely not there yet. And the standard is, like, I truthfully, I would not do the surgery at this point. This is why I kind of stopped looking and considering getting a surgical intervention, given my pain levels right now. But yeah, I think we have a long way to go.
I mean, so even the what was it, 3D CT that you had done, even that's not enough. That doesn't give you enough information to make informed decisions about.
I think that you can get a lot of information, so that should be a standard prior to performing these interventions or realigning the joints. But the actual surgical technique and what we do with that information has not been researched enough to know and perform surgeries based off the information that we get from a rotational CT scan.
Okay. And you're a PhD student of human moves, so you're going to be in position make some changes, right, down the line.
Hopefully. Yeah, preoperative assessment is definitely an interest level. Like, one of my main interest levels is improving the preoperative assessments in order to improve surgical outcomes and kind of base the surgical techniques around.
Yeah, cool. So in the article, you mentioned that surgeons and researchers should be allies. What do you think that looks like in reality? What should it look like?
It's a great question. To me, I feel like, I think a lot of it has to do about the surgical technique is kind of what I was just getting at. I think that a lot more research could be performed on what measures are being taken into account on the surgical level at the time of surgery. What are these surgeons actually considering? Because I think there's a ceiling effect of how well your post-operative outcomes can be based off the surgical technique. And I don't think we give that enough attention or consideration as we should. But even as like a patient researcher communicating with my doctors and my surgeons, I am somebody that's like willing, I'm here, I'm willing to do the work, I want to do the work, I want to find answers, improve these surgeries, and think how like powerful that could be to work together with these surgeons to actually make change. And I just think it could be so impactful, whether that's performing the research on the surgical techniques like I spoke to, or just like opening up the communication lines. Like, the first step would be getting people to listen and open-minded and, just collaboration. Yeah.
Have you had any productive conversations or any unproductive conversations with surgeons?
A lot of unproductive ones as a patient.
Yeah. How about as a researcher?
Not as much. A lot of our research right now is focused on like rehab and trying to figure out mechanisms of muscle dysfunction after ACL injury. So it's not really related to the surgical techniques, even though that's a lot where my interests lie. I did have one surgeon, actually the godfather of rotational deformities, that I speak to in the blog. He was probably the most communicative with me, and he sent me articles, he sent me emails, he like explained my case more than like anybody ever had. And that was really just awesome to see as a patient side, because it was like he was trying to help me learn, and we would go back and forth, which was really nice. But that was the first time that had happened. I would love to like shadow him one day and see how he's performing his surgeries and stuff like that. So
cool. All right, let's see. Any more patient questions? Okay, so so in the blog, you mentioned that you work on you've been working to substantiate claims that guide much of our therapeutic practice. Can you talk about that?
Yeah, I think a lot of that has to do I think there's another question about the methodology. So I think
answer both.
Yeah, I think like the broader answer about substantiating claims is really related to the approach that I'm taking, and just trying to get into the details and look at data a little bit differently than maybe we were previously, and bring in more information. I think that's a big one. So I can kind of talk to the methodology too if we want to do that, because basically I think that's really how I'm trying to answer that question. So in our research, kind of the first project I really worked on was a functional data analysis. So traditionally, biomechanists look at like peak knee flexion angle. I can actually share my screen for this too. Peak knee flexion angles and like, let me pull this up first.
Well, the peak knee flexion angle seems to be pretty important.
While it's important, there's a lot of other information that we can get from that data. Let me share screen.
If you just leave your screen shared, we can. I can just bring it up and down.
Oh, okay.
So you don't have to unshare it every time.
Okay. So yeah, like traditionally, you can see this, right?
Yep, looks good.
Okay. Yeah, traditionally biomechanists look at like peaks, so peak knee flexion angle, peak knee flexion moment, peak power, and really that's only looking at like one percentage of the step cycle, right? You can know if there's differences in when that's occurring, not when it's occurring, the magnitude of differences, but it doesn't tell you when and the timing of that. So you can incorporate a functional data analysis that allows you to compare the entire trajectory of peak knee flexion over the entire step cycle or stance. And that kind of gives you information about the magnitude and the timing, which is, timing is also important. So kind of this first study is more of a proof of concept study. So it was less about the actual clinical utility of this, but we did it in ACL subjects who had received reconstruction. They were cleared to return to sport, and they all passed HOP testing. So we collected this data during the triple HOP. So they all were able to achieve over a 90% limb symmetry index for HOP distance. And what we found in it was that they're unable to absorb the same amount of energy in their ACL limb during loading, and that basically occurs at an early time in stance and during early loading, where the ACL is really susceptible to injury. So other than just knowing that they have a deficit in how much power they're able to absorb, really focusing on early loading strategies and eccentric exercises during early loading could be beneficial as a targeted intervention. But that's, again, this is a proof of concept study, but we could do further studies to look at, the clinical utility of that information and see, maybe these patients are at higher risk later on down the road.
Yeah. So I didn't read that study, but that you presented that data at the ACL research retreat, right? And
yes, that was
2017.
Yes. Yep.
So is that what you're talking about, where you're looking a little bit more into depth about not just peak knee flexion, but when it's occurring through the loading cycle?
Correct. Yeah.
Yeah.
Basically, like the overarching theme is to try to bring in more data and more information and kind of look at it a different way. So we have kind of extended that to our different MRI technologies that are looking at basically the tissue quality and tissue health. And instead of usually with those metrics, people look at, they kind of like dumb data down to one value, but there's a lot of other information that we get. And by doing that, we can lose out on important information. And specifically, like there's regional differences of the muscle. So you look at like muscle biopsy literature, it's only looking at a small fraction of the muscle, but it's not necessarily representative of what's occurring along the entire muscle. So by looking at like regional differences and bringing in more data, we're able to look at the data differently than what's previously been done or is done less commonly, and try to understand what's really happening along the entire length of the muscle.
Okay.
Yeah, that's kind of part of it. I think the major methodology study that I've kind of like overhauled was an ultrasound study that I originally really wasn't intended to be on. So I was originally just helping to implement like an open source code of tracking muscle fascicle behavior, which is what you see in this bottom right image. So really the study the goal of the study is to look at fascicle and tendon behavior in vivo after ACL injury and reconstruction. And when I was helping to implement this program to track the fascicle behavior, I kind of realized how many limitations there were in this type of data. And then the study basically ended up being transferred to our university. So I kind of got a lot of freedom to be able to make it my own, I guess. And by doing so, I incorporated a lot of changes. One being that basically the probe can introduce a lot of errors based off the tilt. So that's what you see in this top right image here. Just like angles can introduce errors into the fascicle behavior here. So basically, we got new mounts. I worked with a company called Usono. So we're able to get new mounts in order to basically limit movement of the probe. And then also we're able to track probe movement. So any movement of the probe, we're now able to track that. So that's part of the data collection side.
You're having people like jump with this probe on their thigh, right?
This is during walking. Yeah, so we're looking at intended behavior during walking. Basically, like there's decoupling of the fascicle and the tendon in a way that's basically beneficial to promote force generation and power production. So we're trying to investigate that after ACL injury to see basically other intrinsic properties of the muscle changing and try and see what's going on. So traditionally people look to, in order to get like tendon mechanics, we have to put this, we use like joint angles and the patellar moment arm to really figure out tendon behavior. So we put it into regression equations and we're able to determine how much movement is occurring along the tendon. So rather than doing that, we basically added a second probe and we're going to collect the basically movement of the MTJ after as well as the fascicles. So we're putting two probes on the limb, which was a challenge to fit on because you have limited space. So it's a lot of stuff on a limb, but we're going to get more information and it should be basically between the probe orientation, probe movement, and estimating tendon behavior using these regression equations. It introduces a lot of errors in fascicle movement, or it can overestimate tendon behavior or fascicle behavior. So by basically making these changes, hopefully we'll get, be more confident in our data on the data collection side. Yeah.
Yeah. And where are you? This is a study you're currently working on. So tendon fascicle behavior in walking after ACL reconstruction. Like, am I getting that right?
Yep. Yep.
Okay. And then, and you're currently collecting data right now?
We are gearing up to start collecting data, hopefully.
Okay.
Yeah.
Right. And this,
Go ahead.
So just so I understand though, this is different than maybe other similar studies because you're looking a little bit more critically about how the actual images are captured and processed. I mean, you mentioned open source code, and to someone like me that doesn't mean a whole lot. Like, what is that?
Okay, sorry.
Is it some of the processing information?
Yeah, so open source code is kind of basically people create applications or programs in order to that it's freely available to other users. So meaning before where at our old university, we were using a program called Dartfish, which allows you to manually track fibers in each frame. So you'd like draw.
Okay.
I don't know the actual details. I never used Dartfish, but you have to manually track the fiber in every single frame. So it's a program called Ultrasound was released, and it allows you to really, it's semi-automatic. So it's able to use a tracking algorithm to identify the fascicle and track it along frames automatically, where you can do manual corrections to it. And basically there's limitations in all of the methods, where there was manual method using Dartfish or semi-automatic method. And some of those limitations it's kind of hard to explain, but one of them is it assumes fascicles are linear, which sometimes there's curvature, so it doesn't account for that. Another limitation is that you can, in some of the programs, you can only look at single fiber dynamics, so you can't look at multiple fibers across one frame. And it's been shown that fibers behave differently in different regions of the muscle, so more superficial or deep. So the flexibility to do that wasn't there. And then tendon behavior was also something that was going to have to be tracked because there wasn't a to my knowledge, there was not a current open source program at the time that was readily available. So you really have to develop those processing techniques on your own. So basically, over the past year, I've really been working on developing an application to do this, where I have that flexibility to look at single fiber dynamics and regional differences in fiber dynamics, along with the tendon mechanics as well. So I'm hoping to bring in more information in that realm as well. Yeah.
This sounds so cool. I'm gonna ask you to speculate here a little bit. Like, what do you foresee this specific application being useful for in clinical cases? How might you see this informing my practice in the future?
Yeah, I mean, hopefully it's definitely speculating, but we're trying to understand the mechanisms of muscle dysfunction after injury. So understanding these intrinsic properties of muscle will help us to understand what's actually occurring. So we can understand the mechanisms of muscle dysfunction. We can better develop interventional strategies that could then be, you could target in rehab, but without really understanding the mechanisms, we're kind of, we don't truly know what is occurring and why it's occurring, why this, persistent weakness is occurring long-term. So hopefully we'll be able to better understand mechanisms of muscle dysfunction, so then we can develop and, properly.
I love it.
Attend to some of this.
So Lindsay did our a Q&A. I think she and Dusty did the first one.
Yeah.
And she said something that stuck with me, and that's that you have a very sick muscle after an ACL injury. And I thought that was a very, powerful way to talk about that. And you don't think I hadn't thought of it to that point. And I don't think most clinicians do. So I think that's really great, bringing light to it.
Yeah. So she has a great way of describing what's actually occurring.
Yeah. I have a question, methodological question about your study, and I'm basing it off of the study that you sent me, which is, I think, similar. And they were doing counter movement jumps in that study. That's why I was asking about jumping. But are you controlling for like stimulants, like CNS stimulants, or like you're gonna let people drink coffee in the morning that they walk for you? Will that change excitability of a muscle and fascial behavior?
Yes.
Okay.
I know we definitely exclude stimulants.
Yeah.
Certain medications. I'm not 100% sure on coffee. I have to ask about that because we haven't started collecting data. But definitely stimulants.
My favorite stimulant. Yeah.
Yeah, I think there's it definitely would influence muscle activation.
What are some other things? What are some other things that can affect muscle activation? I mean, are you looking at people with is joint swelling going to be part of the study, because a swollen joint, is yields inhibited muscles? Is that something? I mean, there's probably, I'm sure there's a list of things. I'm just curious.
Yeah, we are not controlling for swelling. We're not looking at that. I think our time points are. What are our time points? I think they're after return to sport. They're at 18 months after cell reconstruction.
I hope they're not swelling at that point.
Yeah, they should. It's far after the surgery. So we're not looking at swelling, but definitely a lot of things can influence.
Okay, I want to talk about this other study that you recently published. So actually, I did a Q&A with Alana Arjos. She's at University of Delaware. She's doing some really cool gait research using split belt treadmill training, and this article came up in our conversation because it was kind of fresh on my mind. We were talking about gait changes after ACL injury, and so you published a study titled "The Relationship Between Altered Knee Kinematics and Subchondral Bone Remodeling in a Clinically Translational Model of ACL Injury," and I just want to know, you guys put you guys put a picture of the rat, the ACL terrorizer, in there, and whose idea was it to name it that? That's clever and dark. Who did that? Is that you?
I have to admit that I'm 99% sure that was Lindsay.
Okay.
The creative one here. Yeah, I think she created that with her advisor at Kentucky.
Yeah.
Yeah, so all the credit goes to her for that one.
Okay. All right. That's cool.
Yeah.
I mean, I'm impressed the idea that you could devise a device to just tear ACLs in rats.
Yeah, it's yeah, honestly, I wasn't here during the development of that device, so I can't speak so much about that. But it is pretty yeah, at the time of starting my PhD, I was like, what? You tear their ACLs?
Yeah.
How does that happen?
Yeah.
Yeah,
And
so
very successfully too. Yeah.
yeah, we do. It's very
That's great.
reliable.
And so someone got in there and did a little rat lockman, I read,
Yep.
which is kind of funny. I could just picture that.
Yeah, that's
And then
very small.
and then you did, because you looked at their gait, you looked at the rat gait at 7, 14, 28, and 56 days. And I mean, I would imagine, so using a mark ruleless system, but I mean, like you're just collecting tons of data, right? On these tiny little gait cycles.
Yes, we have a ton of data on tiny little gait cycles. Yeah, that's basically what we did. And then I applied that functional data analysis to see how it was changing over time. Yeah, there were a lot of significant differences at every time point, and more prominently at the later time points of 28 and 56.
Yeah.
But we had a lot of data for sure. Yeah, we had 56 rats. So
56 rats. And well, each one only got one trial of walking, right? And then there was
correct. Yep. I know.
Those poor little rats. Okay. And so in the gait cycle, you didn't just note. So you did sagittal plane kinematics, and you looked at knee flexion, peak knee flexion, and so peak knee flexion was decreased at all stages except for day 14. It was increased.
Yeah, in the are you looking at the males? Let's see.
You know, I didn't differ in my notes here that I was taking. It looked like it was increased in both females and males.
Okay.
4 to 5 in females and 5 to 6 in males. So it's just a 5 to 8% increase. I'm just curious. I mean, that was kind of curious because it was decreased in all the other time points.
Yeah, if you're looking at just the peak, it technically is increased. There were changes occurring. I'm looking at it earlier in the subcycle that were more prominent. It's kind of showing like a weird. I can share my screen again. Well, I can share my screen again, but it's not really working. So. Yeah, I can't share my screen. I don't know what's going on with my mouse over here, but
okay.
Basically there were changes earlier in the subcycle, and then that was followed by an increase in peak knee flexion at day 14. Yeah, I guess I can't really explain that one that much, but
yeah, just curious. And then sort of day 56, you'd expect them to starting to normalize their gait. What's that? 6 weeks, 7 weeks? Almost 8 weeks post injury.
Yeah.
And those changes were pretty locked in there. And I don't know what to do with this information, but I appreciate that you broke it down into phases of stance. You know, you said like there's a 6 to 10% decrease during 1 to 5%, which is like the initial contact, right? Or when the heel hits. Do they have heels? Yeah. Do rats have heels? Okay.
Pause. I don't know either.
Okay. All right. Yeah. But I appreciate that. I don't know exactly what to do with that information, but I appreciate the detail that you guys went into putting it in there. And it was a fun read. Took me a while to get through that article, but I did it. And then you found subchondral bone plate porosity increases in the porousness of the bone and the thinning, right? The cortical thinning was present as well. That's terrifying. That scares the crap out of me, thinking that if you tear your ACL, you know, you're looking at, you know, the bone is going to get weaker. And as a result, the cartilage is going to take a hit. Yeah,
that's, I mean, that was probably the most important finding, was that the peak knee flexion angle is related to joint porosity, which influences the ability of the cartilage to really dampen and distribute load properly. So, Yeah, I mean, I don't. We have to remember that these are rats, so we have to, they walk differently than humans, and there's a lot of, there are some differences that we can't, ignore. But
sure. Yeah, I mean, yeah. But I'm a clinician, and I see this.
I know.
I'm gonna do something about this.
There are changes that occur at the bone, prior to the cartilage. So that was probably the main finding. So I think in our future study, we're going to try to look at more advanced cartilage imaging to really get a better idea of how that's being influenced as well.
Yeah. So, and you're going to keep using rats?
Correct. Yes.
Okay. Could you put a rehab arm in there, and I'll come and I'll rehab these little rats? And we can do like a wait and see arm and a rehab arm, and I'll be the rehab.
Oh man, that'd be awesome. Honestly, we would probably go for it. So.
Let's see here. I made some notes. So the reason this came up, actually, now that I'm remembering, with Alana, was that to me, I'm not super well read on gait literature after ACL, but to me, this was sort of like definitive proof that gait abnormalities or changes in gait are really linked to progressive arthritis after an ACL injury. Am I giving you guys too much credit? Because
I think so.
Okay.
I don't. I wish Lindsay was here to answer this question. I mean, it's an important finding because it is linking together an important clinical measure that's used very commonly, peak knee flexion angle, and a measure that's a hallmark measure of osteoarthritis. So it is an important finding, and it was the first to make that clinical measure relationship between the clinical measure and OA. But yeah, I don't know. I don't know. We have to ask Lindsay that one. I don't want to give us like too much credit or something. There are limitations also. There's always limitations. So, but
sure,
this was.
Sure, we'll answer that in the follow-up study with the rehab arm too, right?
Yeah, I would love once I get information about the, not the rehab, but the cartilage information to see how that's being influenced as well, and muscle dysfunction as well. But yeah, I mean, it is an important finding. We found a clear link between peak knee flexion angle and porosity, which is meaningful.
Well, yeah, no, I'm glad. I'm glad to read it. No, I appreciate that work, and you'll always have clinicians, sort of like, we're trying to make links here. We're trying to find actionable items and stuff, and so I don't know if you regularly speak with clinicians, but maybe it would just frustrate you. But
no, that's honestly that actually helps me because I'm not. That's like an area to improve in. I like the very deep details, but I'm not always like bring my head up and look at how it's all linking together. So
and if we're being honest, there's not a ton of clinicians that are reading a ton of research. So if you do get a clinician who reads research, you should hold on to them and never let them go. This is okay. So one other question. So you mentioned looking a little bit more closely at the cartilage using different imaging techniques. So I was going to ask if CT scan is the only way to assess for porosity, or what might be better.
For porosity, CT scan is what is used, I think.
Okay.
Like that's what we did. We used Measure CT. We didn't collect MRIs to look at cartilage. But there are different like staining techniques that you could use to look at cartilage as well. So we actually, basically most of my focus for the past year has been all of our human collection, which has been the ultrasound. So once we get that up and going, we're going to, dive deeper into the methods for actually collecting that cartilage imaging and seeing what information we can get from it. So that's to be determined, I guess.
All right. Well, I can't wait to find out what you and your group put together. those are all the questions I have. You answered every single question I could come up with, or we fielded from the audience. Is there anything? Is there anything you want to share about research or patient experience or anything that we didn't cover that you want said?
I just think this is not really related to anything in particular, but the value of learning and hearing from different perspectives. I think that we'd all really benefit from more collaboration and less competition and working together across different fields and different, working with clinicians and working with the surgeons and just working together. I just think there's so much value in different perspectives that we don't always utilize. And I hope to bridge that gap somehow in the future, so that's open mind.
Well, yeah, I think this is one way. I mean, and I appreciate you writing a blog post, and I appreciate you sitting down to talk with me and answer my questions. This was super fun. I had a great time, and I really appreciate learning from you. Thank you.
Oh no, thank you. Thank you for the opportunity to share some of our work and some of my stories. So it was great.
Excellent. Okay, well, so for anyone who's still watching out there, we have one last blog post. It's Keith Nur, and he's going to do running. He's going to do a post on running after ACL injury. So, and then I'll sit down with Keith just like this in a couple of weeks, and we'll do this one last time. McKenzie, thank you for your time today.
Thank you so much.
All right.
All right. Bye.